Good evening, everybody. Welcome to this Improving Childhood Asthma Management ICAM Community of Practice. The topic this evening is Back to School 2026. We'll just wait for everybody to join from the waiting room. Just a few more still coming in. Okie doke. In the interest of time, can I just check everybody can see the slides up on the main screen? Great. So as I say, welcome everybody, those who are new, those who are familiar faces. This is our first ICAM for January for 2026, and the topic is back to school. Hopefully we will cover everything that you need to know for the impending school term and children's asthma needs. So in the acknowledgement of country, in the spirit of reconciliation, we acknowledge the traditional custodians of the lands on which we meet, the Wurundjeri people of the Kulin Nation. We pay our respects to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islanders people here today, for they are the safekeepers of memories, traditions and culture. We recognise their connection to country, land and sea and community, and the role in caring for and maintaining country over thousands of years. May their strength and wisdom be with us today. Just some housekeeping. If everybody can keep muted unless you're asking a question, and you can ask questions via the chat box, which will be monitored by our lovely paediatrician, Catherine Chen. We'll try and answer questions as they go at the end of topics in a very informal way. The session is being recorded and you'll be able to access the recording after the webinar. Please ensure you join the session using the name you registered with so we can mark your attendance, and that's crucial for getting your CPD points. So just a quick slide on how to change your name in a Zoom meeting. You just click on participants. If you're using the app, you click on your name. A computer, you hover over your name and click the three dots, and on a Mac, hover over your name and click more. And then just rename, ensuring it's the same as the name you registered with, which will be on your registration link in your email. By the end of the session, I hope you'll be able to implement best practice management for asthma in children, describe resources, local services available to children living with asthma in the Western suburbs, and identify collaborative multidisciplinary opportunities to improve the care for children living with asthma. Perhaps we'll be able to interpret some local data and identify potential solutions to improve asthma care locally. Your facilitators this evening, as I mentioned, Dr. Catherine Chen, who is a general paediatrician at the Royal Children's Hospital, will be monitoring chat and available to ask questions from. And myself, Kirsty Thomas, I'm a general practitioner in Truganina in the outer western suburbs of Melbourne. So we usually start the evening with introducing yourself with your name, organisation and role in the chat box. This just allows us to know the demographic of people that we're speaking to and everybody to get familiar with each other. So I'll give you a couple of minutes to do that. While that's happening, I will be doing the welcome and introductions today and then going through the GP asthma appointment. This is not a detailed explanation of how to treat asthma, more how to structure an asthma appointment with a new asthma patient. We then are lucky enough to have Elizabeth Spears from CoHealth's Community Asthma Programme to explain in detail how to correctly fill in an asthma action plan and utilise the teach back method in doing so. We then have some answers from the Department of Education on commonly asked questions at this time of year. I'm sure you all know the ones for our asthma patients and parents regarding asthma plans and medication in the context of school. We'll then briefly go over health pathways and the community asthma programme and how these resources can help you in your everyday practice. So thanks everybody for introducing yourselves in the chat. It looks like we've got a really good demographic. We've got some consumers or patients, some nurses, lots of GPs, GP registrars, paediatricians. Welcome all. So I'll be going through the GP asthma appointment. Once again, this is not to teach you all your jobs. This is how, as someone who specialises in paediatric asthma, how I would structure a GP asthma appointment, looking at the salient features and how we collaborate with hospitals and the community asthma programme to do so. So this is the case. You have a new patient booked in, you've received discharge paperwork, and the parents have attended with the child and they're telling you the story. He's a 3-year-old male and he's been referred to you as a new patient, as so many of my patients are, by the community asthma programme. He has repeated episodes of asthma triggered by viral infection, and he's had dental in the community for 4 attacks in the last 10 months. He's had 3 courses of oral steroids, 2 courses of antibiotics, and 2 emergency department admissions to 2 different hospitals. He's had burst therapy each time, and once he required oral steroid in hospital. He was referred directly to the community asthma programme after the 2nd ED admission to a local hospital because he's got no regular GP. He's been seeing whoever the parents can get him in with on the day because he's always presented acutely. So I'm sure we all remember from our GP training the doctor's agenda. So when you're thinking about this patient, thinking, oh great, a 10-minute appointment for a new brittle asthmatic, that's doable. We're thinking, what do we really want to do here? So the acronym MAGIC actually comes from discharge planning within the hospital systems in the western suburbs and within the Royal Children's. This is an acronym they use to make sure they've ticked off all the salient points before discharging a patient back to the community. Their acronym changes slightly. There's medication, asthma plan, GP follow-up, inhaler technique, and C, which Catherine's completely gone out my head again. You're going to have to remind me.
Community asthma program, just to make sure we refer
program.
them to the asthma program.
Yep. Despite me going to be talking to you about 100 times this evening, for some reason C always drops out my head. So I've used this acronym as they use it for discharge planning and tailored it for the GP appointment. So first of all, we'll go through medication, ascertain the full history of this little chap, and then we're going to do a bit of GP orientation. And what I mean by that is explain to this family who don't have a regular GP what our job is, why we're important, and also just remind everybody how we can utilise MBS funding to help support our job and this young man's health. We're then obviously going to talk through inhaler technique, which I'll leave Libby to do in more details because she is fantastic at it. And then C is for clarification. Clarification is that crossing the bridge part of your appointment where you've given the diagnosis, you've explained your management plan, and then we're looping back and really saying, this is what I really want you to take home. This is asthma and what we expect from you guys, what you should expect from us. So going into any new patient's appointment, I'm thinking about these things. Now, obviously, that is a lot to do in 10 minutes. So I'll break it down into how I would do it in the first 10 minutes and what I would do at a follow-up appointment, or if the Holy Grail has happened and if they have booked a 20-minute appointment, we can get all this done. So we all must remember the power of communication and that there is not just the doctor's agenda, but there's the patient's agenda. Now, this is a compilation of my listening to not just our consumers, but our patients over the last 3 years of working as a GP who specialises in paediatric asthma. And correct me if I'm wrong, we have consumers in the room. Please tell me in the chat if there's things I've missed or if there are things you would add. But the patient's agenda seems to centre around continuity of care. Who's responsible for my son and his healthcare other than ourselves? A clarity of diagnosis. Because preschool asthma has changed so much in the last few years, a lot of these children started off being told it's just a virus, it's viral induced wheeze. They're too young to be diagnosed with asthma. And really, we know from speaking to consumers, being able to hang our hat on a diagnosis is so important to them, to understanding their child's illness, is so important to their healthcare education, but it's also really important to explain why we're giving asthma medications and asthma plans and then saying, but it's not asthma, because it is asthma. Uncertainty with medication, not sure about things like steroid inhalers, oral steroids, repeated courses of antibiotics, what's their purpose, what harm they will do to the child. Fear of the acuity. We've all treated children with acute asthma. It's tricky. And if you don't have history in asthma and you're a parent looking after a very young child who's struggling to breathe, that's really terrifying. All the paperwork which is involved, which we know very well. Where to get more asthma education other than just from their GP. People have an endless amount of resources at their fingertips. Some of them are really helpful and some of them aren't so helpful. So signposting to appropriate asthma education. And then where to next? What do we do after this? So we start the consult. First of all, we've taken the acute presenting history. We have the discharge paperwork. We know this is an asthmatic child. But really, if I've only got 10 minutes, what I'm wanting to clarify there and then is medication. Because if this child has another brittle attack, we need to know that he's got the right medication at home and that he's on something that's going to prevent this in the future. So currently this child is got Ventolin 2 puffs as required, outlined on the asthma plan as created by the community asthma programme very helpfully for me. A new prescription of Flixitide Junior 1 puff twice a day as a preventer, which has been explained to him by the community asthma programme. The other thing with medication is I clarify the total steroid dose over the last year and the total Ventolin use. Why? Well, I'm sure you're all really, really comfortable with the question, but it's a steroid. I don't want to give my kids steroid. I don't want them to be short. What about their oral hygiene? So I really try and clarify, one, has this child reached the critical threshold of oral steroid, or have they still had a small amount, but can we really put the context of what inhaled steroid is versus oral steroid to do that teach back to the parents of the comparison between the two, which we'll go through later, and the difference between the two. Now, in terms of total Ventolin use, he's had 4 canister in the last 10 months. Now, we know that the amount of canisters of Ventolin used can predict acuity, but also chance of death. If someone has used more than 12 canisters in 12 months, their likelihood of dying from asthma is significantly raised. That's because, and again, this isn't so much teach you about asthma. We've covered this a lot in the last 3 years, but just for those who may be new, recurrent Ventolin use at that level tells us that there is an uncontrolled inflammatory component in the lungs, which is obviously the basic physiology of asthma, that requires inhaled steroid to control it. There's also a paradoxical reactivity in the lungs to increase Ventolin use that can make the child more reactive and less responsive to Ventolin. If you're wanting more information on that, we've got lots of webinars. If you email Olivia, I can help signpost her to which one that you would want to watch. The other thing is clarifying the antibiotics prescribed and why. So he's had amoxicillin twice for crackles in the chest. And in the C part of this, I really go into antibiotics. Some people are really pro, some patients are really pro antibiotics. I want antibiotics, he's got an infection, he needs them. And we have to explain the difference between bacterial and viral infections, as you all know. And some are really anti-antibiotics. And then allergies. So for this point, I would say medication allergies. Okay, so we're really getting this down and making sure that he's on a preventer, making sure that he has not reached critical threshold of oral steroid, and explaining 1 year's worth of Flixitide at this dose is roughly equivalent to 1 day's worth of oral steroid, which we've clarified with the pharmacist on one of our working groups. So then ascertain the full history, and I'll really try and get this in the first appointment as well, just to plan my second appointment as well. So we're looking at birth history and past medical history. We all know how to take this history. The real things I'm looking at is prematurity, any lung injury, history of bronchiolitis. Bronchiolitis doesn't mean your child will become asthmatic, but often there is an overlap from bronchiolitis into asthma around the 12-month age group that can be very confusing. I think it's really important to ascertain if that's happened, because it's a real good point for the clarification for patients to explain the difference between the two and why one day we say it's bronchiolitis and then kind of the next we say it's asthma. And I'm presuming everybody knows about the development of the receptors in the lungs that are responsive to Ventolin and when that happens. I'm also taking a developmental history. Neurodiversity and disability are really important. Neurodiversity, obviously, for communication needs for the child, ability to follow instructions such as ADHD, cognitive understanding. And with disability, I'm thinking about things like cerebral palsy, any neuromuscular disability that might impair their lung function or make them more prone to respiratory diseases. We're talking about vaccinations, so all their childhood vaccinations to be up to date, an annual influenza for this child, and a pneumococcal vaccine. So pneumococcal is obviously involved in the childhood vaccinations, but one-off 20 PCV diagnosis is recommended if the child has severe asthma. And really for any child on a preventer with this amount of admissions, I'd be talking to the parents about whether they wanted a pneumococcal vaccine in addition. Allergies other than food allergies are really important. Again, we've covered this topic every year in previous webinars. So if you want to know more about this, please reach out to our administrator, Olivia, and we can send you the appropriate webinars for more learning around this. But the salient ones for me are hay fever, especially in Melbourne, food allergies, animal allergies, and house dust mite. Obviously, any allergies are important, but these ones I would specifically target in my asthma consult. And then obviously looking at the family history of asthma and atopy, one, just to explain it in the patient's terms, but also perhaps you do have a family who have a professional patient on board with asthma, which always helps. ATSI heritage is really important as well for vaccination status and access to other NBS funded things that they can get through the GP. And then social. So are they at kinder? We know how many viruses that kinder kids get: exposure to smoking, vape, and housing. Not so much a problem in some areas that you will work in, but mold and damp housing can really make a difference to kids' lungs. House visits for kids aren't really done in Australia, as far as I've seen in the last decade, but the community asthma programme can be really helpful here. If the family are worried about a housing issue, the community asthma programme can actually visit the patients in their house, not to do a mold assessment, obviously, but to look and see what the parents are worried about and see if it's something concerning that we do need to address. So that's what I would cover in the first 10 minutes. And if we can get that down, my next point of contact would be saying, right, we've got a really good setup here. We've got down the history really in 10 minutes. That's all I've got today. We know he's on the right medication. The community asthma programme have seen him. We're not worried about everything deteriorating acutely. He's just been in hospital. Let's bring you back for a 20-minute appointment because we've got everything else to do. And I'll explain everything else as I'm going to now. Again, it may be the Holy Grail. Perhaps we have 20 minutes and we can do it all in a winner. So then I'm going to be moving on to G. Right, we've got the history down. We know who you are now. What's the point in me? What am I going to do for you? So the first thing, as we all know, one of the most important tools we have in that birth to death service is developing rapport. So this kid's got no regular GP, multiple care providers, numerous different diagnoses and information given. We want to really be saying, hey, we know what we're talking about. We treat pediatric asthma. I'm here for you. You can make appointments. This is the structure. This is who we are as a practice. And offering the opportunity to say no as well, saying you're not the right fit for us. You're actually miles away. Do you know anybody else in the area? So really GP orientation is explaining to the patient, this is what I do. This is my background in it, and this is why I'm useful. We're talking about the paperwork side of things, the asthma plan, which Libby will go through in detail, and this child already has, but I'll be developing that for them if they don't have it, and explaining that they need copies for home, for daycare, for kinder, and any other care providers. So I usually say screenshot it, send it to grandma and grandpa, print it out, put it in a Polly Pocket, put it on their fridge, have it somewhere visible. There's no need to be in colour, and any plan needs to be accepted. We've got a whole section on this later in the talk. I just put it here as a check mark to explain what the Department of Education's formal guidance is on asthma care plans. I then also go on to explain my Medicare briefly. You'll all have your own setups for this. I then offer to go through to the nurse after the appointment, discuss it in more details, explain the benefits, including extended telehealth consultations. Obviously, we get 20 minutes, and the structure of care plans and the legalities of doing care plans under my Medicare. And then also I offer a care plan, obviously not in the first consult, but explain that if they plan to have ongoing consults with me, if I'm going to be their regular GP, they have a chronic condition, and we should structure a care plan accordingly. So I am going to skip over this actually, as we had an answer from the Department of Education, but this is just briefly what the asthma policy is. At the top, that is the website that you can refer patients to read through or refer their schools to. But we'll go through this bit in a bit more detail later on. So this is what I put in the top of my care plan. I'm sure you'll all do the same thing, but for my asthma patients, I have my preschool asthma patients, I have a cut and paste Word document that I put in the diagnosis section. It will be attached to the post-webinar utilities. Feel very free to use it, modify as you need. I will modify certain things for certain patients, but it's generally just an overview of asthma for the patient, covering the most common questions I get and that we have gotten as part of this ICAM over the last 3 years. So I try and keep it really simple and just say any child 5 years, and this is preschool asthma, obviously asthma is a lifelong condition, but any child 5 years and under with wheeze and respiratory symptoms responding to Ventolin and salbutamol is now termed preschool asthma, regardless of the trigger or frequency of events. So it doesn't matter if it's viral, if it's hairspray, if it's smoke, if they respond to Ventolin and salbutamol, they've had more than 2 episodes, this is asthma. We call it asthma because it reduces confusion amongst patient caregivers and healthcare professionals, and so that we can standardise our care. It reflects the commonality of children with Ventolin responsive respiratory symptoms to be at increased risk of hospital attendance and admission. Your child may grow out of this diagnosis if they have no symptoms for at least 1 year. You should, and they should be aware though, that asthma can return later in life in response to new or unknown triggers. I would like to get that point in. We have lots of kids who grow out of asthma, and then I see them about 10 years later, and suddenly they're coughing again. I said, oh, remember that asthma you grew out of? It's back. And I think it's really important to let parents know, because often kids will grow out at an age they won't remember. So to let parents know, to tell their children, hey, you were asthmatic as a child. So in the care plan section, I also put common asthma triggers, which are listed there. Just because some patients generally don't know what triggers asthma, and that parents need to be aware of their child's triggers as per the asthma plan and what can trigger your child. We've got a wonderful consumer who will probably be about 19 now, but she used to talk
Oh, we seem to have lost you, Kirsty.
Oh, hello.
Hello, do you mind repeating what you just said? I think you've cut out slightly.
Oh, where did I cut out, Olivia?
Right when you were about to talk about the 19-year-old consumer.
Oh yeah, our lovely consumer who was really on her asthma, a model patient, and she knew all her triggers and was changing at school after PE, and somebody sprayed hairspray and she had a big asthma attack. So just to be a reminder that different things can trigger asthma throughout your life. So I then say roughly go through the treatment. You should have an asthma plan. It should be kept in a visible place, as I said, and photographed and kept on your phone in case you're abroad. You don't need separate plans for school and home. It can be the same plan. Plans can be in colour, black and white. Make sure you check the inhaler expiry date and the doses left. Make sure you clean your spacer regularly when it gets cloudy. And if you're using the Ventolin more than twice a week, you need to see your GP. And then I put a little bit blurb of allergies. Again, I'm not going to go into how important allergy control is asthma, but it is. If you want more information on that, we can send you the appropriate webinar. We just don't have scope in tonight's webinar to go through it. I apologise. And then I have a section on resources, and I feel that patients, I get the most feedback on this and how useful. So just reiterating again that we should be the regular point of contact for childhood asthma, and having a regular GP increases continuity of care and facilitates management. At least 6 monthly inhaler and spacer techniques. The pharmacist can do this, the practice nurse, the community asthma programme. We can arrange home visits through the medication review system from a pharmacist if they're really struggling, and it's free. The Asthma Australia hotline, so they can call 1-800-ASTHMA if anybody's not aware of this, Monday to Friday 9 to 3 and get 9 to 5 to get through to an asthma educator. This is not a treatment line. They don't give clinical advice. It's my doctor was talking about this thing and I looked on the internet and I can't remember what it was. Can you walk me through it? They'll take a full history and they'll give printed and emailed documents to the parents afterwards. And you can phone as many times as you like. That we can refer to the community asthma service at CoHealth, which I do with all new patients, and we'll go through again a little bit later. And the Asthma Australian National Asthma Councils are the websites I refer to. The Royal Children's Hospital has asthma education on their website. And then one of the most well-used services is the Victorian Virtual ED service for advice and review if you think they don't need to attend an ED. And I leave the website there. It's invaluable for patients and parents with new asthma in those wee hours in the morning when your kid's struggling to breathe or coughing, almost always coughing as well, because they cough with coughs and colds, not just asthma, to phone and have that telehealth service from the VBED. For anybody who's not used it or isn't familiar with their full service, the Victorian Virtual Emergency Department actually has a virtual asthma ward that the parent and family can stay on, which means they will be kept on a virtual ward and phoned at periodic time intervals for up to, Catherine, maybe you know, is it up to 4 days they can stay?
I'm not sure how many
Yeah, it's a
days.
while. It's not just
Yeah.
24 hours. It's a few days they can stay to cover holidays and things. They for experienced parents, they will walk parents going through burst therapy as well. And obviously they have that video link service to call back should your child deteriorate. And it really is invaluable for those nighttime exacerbations. So the eye of magic is inhaler technique. Again, I think Libby will go through this a little bit, but the things that I go through and the things that I've noticed is almost everybody says, yeah, I've got good technique. I've actually never had a patient tell me they've got bad technique, but we know that over 80% of people, adults and children who take inhalers have terrible technique, actually inadequate. So you really want to be seeing that, even if they have seen the community asthma program. I work really closely with them and often have a patient we've both seen quite a lot. They tell me it's fine, and then I'll maybe get a letter from the community asthma program saying, oh, we're still really struggling. So always make sure you're actually watching the inhaler technique and going through it. I make that a mandatory at every asthma review to watch the technique. They have to bring their medication to the appointments. Flixitide, I think the main messages I get across is this is every day. It is not as required, it's every day. The timing of it, the continuity and why that's important, so you have to take it every day, and rinsing your mouth out afterwards, not brushing your teeth. This is also a time when the steroid inhaler worries come up about height. And again, I'm sure you all have ways that you describe that. Evidence is significant inhaled corticosteroid use over our childhood can cause up to 1 centimetre growth disparity. Now, I usually follow that up with if your child requires that level of inhaled corticosteroid over their life, they might not get to 13 to their maximal child height if we don't treat it. And really emphasizing that we do need to treat with a preventer to prevent life-threatening asthma. And then it comes down to the mouthpiece. So I see a lot of children, even 5 or 6, still with a face mask on. I personally start to ask parents to take the face mask off and play with the mouthpiece and the inhaler from as young as 2. Give it to Teddy, put it in her mouth. If you can suck a lollipop, with practice, every kid's different, and this is why things like neurodiversity are really important to ask. Most children can use a mouthpiece much earlier. It's usually around 4, 3 and 4, but I get them to play around with it so they get really, really used to it for a few reasons. Face masks are really good for a child who is really unwell, but also they make little kids scream their face off. If you're a single parent, trying to give a child an inhaler with a face mask on, it makes them really claustrophobic, really scared. And some kids are really good with it, but sometimes it's almost impossible. It's a really common thing that I see with the parents saying, we just can't get this on. If you do play, you demonstrate it to them with the mouthpiece as opposed to the face mask and get them to big breaths in, out, in, out, in, out. And once you're sure, and this is where the community asthma program really are helpful as well, and once you both agree that they're ready to move on to the mouthpiece, get them onto the mouthpiece as soon as it's appropriate to do so. And then the last point here is clarification. I'll use the last bit of my appointment to explain what we're going to do going forward. Reiterate, this is asthma. You've been told lots of confusing messages over the last year, but I'm here to say this is asthma, 100%. We're a team now, your kid's got asthma. We talked through medication again, just highlighting significance of too much Ventolin if people are still quite attached to Ventolin, reticent about steroid, the importance of inhaled steroid. I talk a bit through the pathophysiology of asthma in simple terms, how it's an inflammatory condition, and Ventolin just relaxes muscles. It doesn't deal with inflammation. The risk of inhaled versus oral steroid we'll go through, and when antibiotics are appropriate. And again, I'm sure I don't need to tell you when antibiotics are appropriate, but I will often say that acute asthmatics sometimes do have crackles in their chest that will clear on giving Ventolin acutely. So I always say, if you're seeing somebody else, give the Ventolin, ask them to listen again. If the crackles have cleared and they're not appearing like they've got a bacterial illness, they probably don't need antibiotics. And then I set the expectations for my patients and the expectations for me. So the expectations for the parents is to really understand asthma is relapsing and remitting in nature, and it can change with age. This is not a curable disease, like eczema, which I'm sure you all get lots of patients back saying, how do I fix it? You can't fix it. Your kid has to grow out of it or not grow out of it. And it will come and go. And really to reiterate again, your child might grow out of it at 6 and then be bothered again at 27. And obviously our focus in this group is pediatric, but as GPs, we are birth to death. So that's part of the context that I use. And then I say follow-up. What I offer to my patients, and everybody obviously practices in different ways, is each flare I offer follow up until they're confident. And by flare, I mean pretty much other cough and cold. And at 3 in kinder, you're seeing these kids almost monthly, because the main confusion I find is what is a cough and cold and what is asthma. So I really say I've got an open door. Every time they have a sniffle and a cough, bring them in. Let's talk about it. Let's that reinforcement of micro learning to really know. And also it really reassures me that the patients are comfortable, the education is coming along, that I know the kid. We've all had those patients who come in after 6 months saying, oh, we've used the Ventolin 3 times, and they were trying to ascertain the history. We're like, is that actually asthma? Did you need to use it 3 times? So I really spend the first sort of 3 to 6 months saying, just come back, just come back, just come back. We bulk bill our pediatric patients, so that's obviously easy for me to do with my patients. But yeah, I really say, really, really come back. I want to see your child's snotty nose. And then once they're stable, we're on board, everything's there, I really encourage them a 3 monthly review for the first year. And that's where I'm redoing the care plan every time, updating the asthma plan if it's needed. And then once they're stable, we can push out to 6 monthly. So thanks very much. If anybody's got any questions, I know it's going over lots of things you know. We just thought it might be useful on those acute new patients. How do we structure a consult, and what are all the things we need to be ticked off, and how do we do that, and get the appropriate funding through a care plan, and time to do so. So just had a quick look at the chat, and it looks like we're all clear there. So we'll move on to a little resource that you can give to your patients. We talk about how we want to structure our appointments, but we've been talking a lot within the working group about whether giving a resource to patients about how they want to structure their appointments and whether it would be useful. Again, we learn a lot in med school and GP school about how to structure an appointment, what our ideas, concerns, our expectations are, how to take the history and then cross the bridge and talk about the treatment and management plan and things. Patients don't know any of this exists. They really don't. They have absolutely no idea what's going on in our head and how we're structuring and running it. And it's really crucial, as we all know in GP, to be able to do that efficiently because we're such a time pressured organisation. So I personally think it's really useful for patients to have a list of things that they bring in. This is a worksheet, and you can create that obviously in your own practice or give them. Sometimes I will print off these things I want you to think about for next time. You write yours ones underneath, and sometimes we'll leave space in the care plan to do that. But this is something that they can access through Asthma Australia, which is the asthma review worksheet. So this is something you can advise them to bring to their annual review if it's a very stable asthmatic and they're just coming in for their back to school plan, which we're about to talk about. And just how to structure in their own head to help facilitate the consult. So we just got a little poll question here. Olivia, if it can come up. So talking about that and how we structure it, we also create resources, and that's something we have the ability to do. If a child has been discharged from hospital, what this question is really asking is if you had a structure like we just showed for a patient to follow that perhaps could come with the discharge paperwork or from the community asthma program. Perhaps you're not so confident, perhaps you're a registrar and you're just getting used to pediatric asthma, which is very different from adult asthma. How useful and how open would you be in your practice for a patient coming in with a structured framework to help you both in the consult? Okay, so I think that's the poll ended. So it looks like it would be very useful to most people. That's great. Okay, so we can take that and feed it back to the working group and see if that's something we can work on with the hospitals. We've been talking about the best way how we would access that. And perhaps put it either in discharge planning or through the community asthma program, have it available in health pathways, some way, so that patients and you can access a consultation framework, a bit like the one I've just discussed. Okay, enough of me. We move on to Libby. Libby is a fantastic asthma nurse who works with the community asthma program in Laverton. She'll explain how her consults go and everything you need to know about asthma plans and how to fill them in.
Thanks, Kirsty. Hi, everyone. For those of you who don't know me, I'm Libby, one of the asthma educators with CoHealth's Community Asthma Program. I'm actually based at Collingwood. Laverton doesn't exist anymore. And we also have our team over in Braybrook as well. So we thought that it might be really useful just to go through some of the important aspects of the asthma action plan, especially at the start of the year when getting ready to go back to school, kinder, childcare. So feel free to drop through any questions in the chat. And I'll take you guys through. Oh, Kirsty, I'm not sure if I can click on it. Sorry. If
Can you
not,
share it from your
you can run me
side?
through. I've got
No?
no slides on my end. Sorry.
Oh, I'm sorry. I don't know what's happened there.
That's
Let
okay. No, it's okay.
me go back
If
to
you
sharing. Okay,
want to click through, that's
there we go,
fine.
yeah. Okay, doke.
So we can go to next slide. So looking when we're going back to school, kinder, childcare, we know that that can be a really high risk period for a lot of children and families. So more often than not, we're in a little bit of a lull at the moment, but most probably as of next week or the week after, we start to see an increase in the hospitals and I'm sure GP land as well of kids presenting with asthma episodes. So there's usually a rise around this time and the reasons that this happens, it can be so varying. It can be from the changes in their routines, from going from over holidays in the summertime to then back to school or kinder or childcare. It can be exposure to viruses from mingling with other, kids and people. Allergens is a big one, all those dusty classrooms that have been sitting stagnant for the last couple of months. And sometimes, more often than not as well, unfortunately, we see that there's a lapse in medications over the summer period too. We forget, we go on holidays, they get back to school. Oh, whoops, we better start that Flexitide again. And those poor little airways just are chasing their tail. So this period is, we find, a really, really valuable time to be able to go through with families that are either coming onto our program or who are already on our program, that information to know how to prevent these asthma episodes from happening or getting, to a point where they may need to go to hospital. Next slide, please. So, like I was just saying, asthma action plans, we know they 100% improve symptom recognition for families. They give them a step to know when to guide through the escalation of, is this just a little cough? Do we give one or two puffs? Do we just wait and see? Or, oh gosh, okay, they're breathing a bit faster. They've got a sniffly nose. I think they might be getting unwell. Do we need to try and give a few more puffs? It means that if we have these plans, they can be shared and communicated between families, between schools, between kinders, between GPs, with community asthma programs. And by doing that, we're empowering these families to know how to use their plans, to be able to follow them, and to know when to seek advice at the correct times. Another thing we know as well is that when they are used really well, they actually do reduce the ED presentations. And like Kirsty was saying before, we're so fortunate now that we have other services like VVED there as well to help support these families in these situations. So it's then about using the plan at that point and knowing what other services that are available for them as well. Next slide. So effective plans, they need to be simple, they need to be personalized, we know, and they need to be easy to follow. Now, I know Kirsty was talking before about that black and white's okay, and we know that's acceptable when going to school, but something that we find really important with our families on our program is teaching them the traffic light system. So that's actually looking at the plan, which I'll show you in a minute, and looking at the colours that are on that plan because they actually follow an hourly system of what we like to get families to be aware of at those hours of what to do for their child and what to start recognising. So if we can get families to know how to utilise those plans, know the colours, know the times, it seems to work best for them to then know what to do at those different steps. Next slide, please. Common issues with a lot of plans that we unfortunately see, particularly with families that are coming onto our program, is that the plan may not be current. So it may not have been reviewed or updated for quite a while. They may not have had it changed or reviewed by their GP when they've had a flare or when they've had a change in their preventer. There may be different medications. They may go to ED and get a plan, but then also have an old plan at home and not know that they need to then update that with childcare, kinder, school. Technique may not be reviewed, like Kirsty was saying before. We need to know that all the time there are different opportunities that we can stop and give families advice on what to do step by step to help to make sure that they're keeping all these things up to date. We see so often that children have asthma or tell a teacher at school, I've got asthma, and they may not even have a plan there or be known as an asthmatic at school. So that's another really important thing that we need to be aware of. These are all system gaps and they're easily fixed if we have these consistent check-ins between all the varying clinicians that they may come into contact with, whether it's at hospital, GP, VVD, community asthma program. Next slide, please. So, how can we make things easier? We can ask if there's a plan that they currently have. We can review the control. So that's doing like an asthma score on them to see where they're at. And then we can actually delve in and ask a little bit about triggers. We know a lot of younger children under that preschool age, so under the age of 6, are commonly viral triggered. But depending on family atopy, depending on obviously as a child ages, the triggers may change as well. And we know that environmental triggers play a big part in some of those. We need to make sure that their scripts are up to date. How often do we find out that the script expired a month ago and they've been using the same puffer for the last 3 months, not actually knowing whether they're actually getting any of that medication coming through their spacer? We want to check their inhaler technique with their inhaler and their spacer technique. And like Hesty was saying, depending on the age of the child, whether we're using a mask, whether we're using a mouthpiece, or for bigger kids, which I'll show you in a minute for their plans, whether they're using like a turbohaler. These are all important things that families need to understand. And it's really important for us to be able to show, demonstrate, and then get them to show us. So doing that teach back method to ensure that they're understanding on a day-to-day process the things that they're needing to do to keep up with their child's asthma. Providing school with copies is so important, and whether it's black and white colour, whether it's from Asthma Australia, whether it's National Asthma Council, whether it's a Royal Children's Plan, hospital plan, it actually doesn't matter. An asthma plan is an asthma plan. They are all very similarly set out. They all guide the families, number one, because that's the number one thing we want to do, with what they need to do when a child is having a flare. And number two, all it's doing is then knowing that that plan's going to school, childcare, kinder, and then they're being flagged as a child that has asthma, so that then if they are having any issues when they're in the care of those people, they know what to do. So it's a little bit different as to how the plan may be used. But I think the most important thing is, number one, the families have it and that they share it with whoever they need to share it with. We want to also encourage families to have regular GP follow-ups, especially when they're on preventers. We often know that there could be increases, so step-ups or step-downs with those preventers, depending on what's been happening with the child. So we really want to encourage our families to be having at least 3 monthly reviews with their GPs when that's the case. And if there hasn't been a preventer on board or there's been no changes, at least 6 monthly. Most like education so schools, kinders and childcares will want new plans every year. Kirsty will go through this in detail. It's not actually mandatory that they have a new plan every year, but it's a request that they like it to be reviewed to ensure that there's been no changes. So whether, they want to just check whether there's been any changes to triggers, changes to the preventer, changes, because as we know from age 6 upwards, the amount of Ventolin changes as well. They're the kinds of things I think that are important to encourage families to get checked and to get updated, that we really always try and help facilitate with our families. Next slide, please. So here's our standard action plan. I'm apologising in advance because we can hardly see the writing on there. We can send these to everyone afterwards if they'd like to have copies of them. But this one was filling out for a child who's under the age of 6 on Flixitide Junior, 1 puff morning, 1 puff at night, so twice a day, needing to have 2 puffs prior to exercise. So we know that that's usually encouraged, that 10 to 15 minutes before exercise. So this is a really important thing just in that top part of that action plan for a school or a kinder to know, for a child to need to have that medication before they're exerting themselves, participating in any sports or physical activities. That's the green area that we would use when they're well controlled. And then you can see it steps down. We have the orange area for at the start of a flare up, pretty much with a preventer, which it's interesting because there's different trains of thoughts on this, but a preventer should always be the same dose regardless of what coloured area they're in. So whether it's the green, the orange or the red area, they have their morning dose, they have their nighttime dose when they're on Flixitide. That doesn't change or increase when they're unwell. The things that we know that they do need when they're unwell is their reliever. So their salbutamol, their Ventolin. So depending on which color square they could be in that the parent has recognized that they could be in is to them what would guide them as to how many puffs they would give and to them when they would seek medical advice. The other really important things that I really want to point out on here as well is obviously making sure that the child's information is clearly labelled. There's a picture of the child because that's an important thing for teachers and carers to know. Emergency contact details of the parents because we know whenever they're given any kind of Ventolin at school, or kinder or childcare, they will call the parent to let them know that they've been given that medication, and then obviously work from there on a plan as to what's next for them. Doctor's details are obviously really important to know as well. The plan date, yep, the plan date's there. It just shows that they went to the doctors on that day, they got the plan done, and a review date is obviously suggested and strongly encouraged, but it doesn't mean that it's going to expire if it goes past that review date. It just means that we would really like the families to try and get back to the DP by around that date to ensure that nothing has changed on the plan. Another really important thing on here is as well is down the bottom with the emergency guidelines. So that then adheres to and what would be on the back of this plan if it was a physical copy is your actual asthma first aid, so your 4x4x4, which I'll go through in a minute as well. That's obviously really important and something that we teach families. I think the really nice thing to know now as well is that in anyone who does a first aid course, asthma first aid is taught in those courses as well. So it's something that I think universally or nationally, I should say, everyone should be aware of. Does anyone have any questions on a plan and how to fill it out or if there's different things that they like to do? The other thing that I suppose I haven't mentioned, sorry, is down on the left-hand side, there's boxes in the orange, so in the flare up and the severe area, which actually lets you write what triggers the child has. So for this child with pop viruses, because we know that's a known trigger for them, sometimes they can change as well. As I was saying before, as the child increases in age, there may be times when they start to notice that it's springtime and there's grasses and they're playing outside and they're starting to have a cough and it's looking like their asthma. So it can change and we can add ones, obviously, as it's needed. There is a thing there for peak flow, but that's not something that we do in children. There is talk that Asthma Australia is going to be making a paediatric form of this plan, but at the moment it's just a standardised plan that can be used for anyone. And the National Asthma Council plan is very similar to this, and the similar colour coding as well with each area. Have I missed anything, Kirsty?
No, I don't think so. I can't
Catherine?
see any
No?
questions.
Yeah.
I probably just for my practice review date. I do a couple of things. Sometimes for the school plan, I'll give the review date in a year to make it easy
Yeah.
for families.
Yeah. Yeah.
As long as I know they're not very brittle or very confused. But usually I'll put the review date after an acute patient, like I just said, which this plan would be appropriate for 6 weeks. So I keep the review date for the family because ultimately this is a plan for family and home care. As Libby will go on to say, the 4x4x4, and this gets quite confusing, lots of people get confused by this, is asthma first aid. Just so the way I describe that to patients is your school is not treating your child's asthma. They're not the chronic healthcare providers for your child's asthma. And the way we're going to educate you and get you to manage and become expert patients in asthma is different from expecting the PE teacher for managing an acute asthma event where they are calling you or calling an ambulance or calling for help. Very different things. Hopefully that makes sense to everybody the way I've explained it.
Yeah. So I think that's the key thing. And I think it's something that we're still obviously in our working group trying to investigate, look into as well, is with these plans, they're general plans at the moment, they're standardized, like we say. So the importance of these plans when giving them to school is to have it known that the child is recognized as an asthmatic. So, and then obviously, like we were saying before, if they needed pre-exercise Ventolin, that would be the other thing. And then knowing their triggers as well would be the third thing. The rest in terms of what's on this plan is purely for the families or I suppose out of school time. that is really important for us to teach families on, and where we use a lot of that teach back of going through each section, going through each colour with an hour of 4, 3, 2, 1 at the hours that they would do things, how much Fentanyl they would give, and then when they would seek medical advice. But in terms of anything else for the education side of things, I don't think there's anything else that they would really use this for. And 100%, it's most schools now are pretty much standardized and stick to asthma first aid, which is your 4 by 4 by 4 for whatever age the child is. Yeah. We can go to the next slide. Thanks.
Libby, can I ask you a question?
Yes.
Some families can get a little bit confused because some of the older children can have, for example, up to 12 puff, and
Mm,
the
mm,
children up to 6 puff.
yeah.
And then they get a bit confused on why do then emergency situation you only use 4 puff. I'm just curious, and how do you explain that to families, that kind of discrepancy in number of puffs?
Yeah. So I think the thing is that, and I'm not sure exactly when it came around and that changed with school. It was quite a long time ago because when I was doing school nursing, which was prior to my educator job, that's how we were treating kids that were coming to our first aid. So I think the important thing when we're explaining to families is this plan is for them when their child is having an acute episode. So when they're using it at home, they're going to stick to what they may be either starting to get when they're going towards hospital, so those higher amounts, as opposed to at school with a poor nurse or a first aid person being confused with, well, which point is this child at? What should I be giving now? Knowing that there's an age difference as well. So under sixes only get up to 6 puffs, over sixes can get up to 12 puffs. There was always so much confusion of where to go. And I remember at one point, like a nurse saying, well, do we just ask the child how much they need? And it was like, well, don't know if that's the right thing either. So that's when I think it came in that with asthma first aid, it was becoming part of first aid training. And then it got implemented. Well, if we're going to use that in first aid training, let's use this across the education side of things so that any person, or particularly a child, is presenting with their asthma symptoms, we can give them that 4 puffs. We can wait those 4 minutes and we can reassess. It's different, I suppose, in terms of an emergency situation. It may not be at school at that emergency point, but it's flagging that there's potentially having an asthma episode that we need to then call the parents, let them know, and then by then work out what our next step is. So by that stage, I'd be hoping that the parents would be shortly on their way and then they could step in and use a plan of what they would be using at home, take them to their GP, whatever it was at whatever point it was. But if it did get to a point where it escalated quite quickly at school, you would do your asthma first aid. You would shake, puff, do your 4 breaths 4 times, wait your 4 minutes, call 000, let them know what was happening and keep going until you had a clinician arrive. So I think that's where it can get very confusing. And we do often spend quite a lot of time trying to explain that to our families because one, we're wanting to teach them asthma first aid, but two, we're trying to explain to them, well, school might do that too, but it might look a little bit different. So yeah, I get it, Catherine. It does get really tricky. I think the main thing is as long as it's like an EpiPen. We know if they're an asthmatic and they've got the Ventolin there, we need to treat them and give it to them and see if it helps them in that episode.
I think
Hope
for
that
me as well,
answered that.
I think it answers brilliantly. From my point of view, a lot of patients ask me in this age group, why can't I just give them 12 puffs? Because they get bursts. I know they need the 12 puffs. And I think parents are often hungry for information and more
Mm,
management ability. And it's in the same way we teach CPR, but we don't do basic CPR in hospital. We do advanced CPR
yeah,
because we have the training. And you're not going to teach a parent necessarily to be a doctor, but you're wanting them to be able to say, oh, you're just coughing a bit overnight. You just need a couple of puffs. Versus if you're coughing in school, you can't treat nuance in first aid. It has to be standardized. It
yeah,
has to be, staying alive 30, it has to be really standardized. So 4 is not over treating a mild asthma, but you have the ability to get to 12, which isn't under treating life-threatening asthma. So
yeah,
I think it's really nice that way, and that's the way I tend to explain it. Is first aid is different from how you and how I will manage your asthma. First aid is standardized training for people who aren't healthcare professionals and aren't being educated rapidly in
yeah,
asthma because they're teaching. for doing
Yeah,
mapping.
absolutely. Yeah. They are getting much better now at doing like getting teachers and even aides and just staff in
Mhm.
general, like whether administrative or not, to do the Asthma Australia asthma course that's online. Because once they do it, actually lasts them 3 years, which is really great. So yeah, I think the awareness is getting out there and it's getting much, much better. Yeah. Moving on. So the big kids plan. So the AIR or MART action plan or SMART plan. So using Symbicort for our over 12s. So for our big kids, once they go off to high school and might still be unfortunately needing to have that preventer, this is the one that they are all having now. Or we're trying to get them to get onto, I should say. We're doing pretty well, I feel like. So Symbicort, so it's combination therapy. So a little bit different looking to our standard action plan, but still really important in that it has all the information that we need for a family to be able to use this at home. So for this one, unfortunately, sorry, again, it's very small. We can see that this child is going to be having their one inhalation of their Symbicort 200/6 in the morning and then one again at night. So it's a BD, so twice daily dose. And when they need it, if they feel like it before exercise, so 15 minutes before exercise, they can have their one inhalation as well. So same thing again, like I said before, for school, that's a really important thing to know. For the footy club, that's a really important thing, or the basketball coach, that is important things for them to know. This one as well, like the other one, goes through your traffic lights, which is really nice for families. It goes through from when they're just on their preventer day to day to when they might be having a flare up to an emergent asthma emergency. The thing that's with this one that we need to understand, it's a different kind of medication. It can be used as a preventer and a reliever. We have kids that are sometimes just prescribed it as a preventer. We have kids that are sometimes prescribed it just as a reliever PRN. It's a very varying group. And it's really important that one, we understand that the plan is filled out properly for that family depending on their needs. And two, the child understands when they can have this medication as well, particularly if it's for a reliever. The amount as well that they can have is different to what it is for Ventolin. So that's something that's really important as well. So it's all written in the plan there. So I'm not sure if you can see it there, but it says that, if they're having a flare up, they can have to a maximum of 12 inhalations in a day. But then it's really important to look over to the asthma emergency. Now, depending on whether they had their Symbicort there or not, is to what they would treat with. So they could either try an inhalation of Symbicort if they had it, and then they would wait their 4 minutes and then see how they felt. And they could then obviously call 000 and have some more. If they didn't have that, they could flick and have Ventolin if they had that there instead. So there's still that option there for children, depending on what's available to them. Say they're at school, they're on a excursion, they've forgotten to take their Symbicort, but luckily school's got their AEK kit, so that's the asthma emergency kit with them. They could treat them with Ventolin for that episode. That's still okay as well. So it's different. Again, it's different. And then the thing is as well, Catherine, I'd love your thoughts on this, or whether you guys are coming across it much in the hospital, is then once they get into an episode where they are in hospital, do they stay on Symbicort or do they go across to having their Ventolin for that burst therapy? Because this is, I think, something that's still being spoken about a lot as well.
Yeah, you're right. This is a really confusing
Yeah.
part. As you mentioned, this is very, very new, and the evidence is very strong for adolescents and young adults to be moving into the combined anti-inflammatory reliever pathway. But in hospitals, as you say, we have been trained so far, and nurses and doctors are very familiar with the Ventolin burst therapy. So at the moment, if you do come into emergency as a big adolescents, even though you are on smart therapy, we do use a standard burst therapy. And once they're better, we then put them back to their original asthma plan. This is the current pathway. And I think there is some studies going on whether we can actually just use the Turbuhaler, the Symbicort Turbuhaler as an acute treatment. I think that give families some confidence that it is very helpful in an acute setting too. But the evidence knowledge isn't quite there, and I think hospital staff is not trained in
No.
that way. And like you say, in emergency situation, we have to go back to what everyone is familiar with. So at this point, it is still the Ventolin burst therapy.
Yeah. Yeah. I think that's really important as well that we educate our families on that in those situations. Um, this is obviously a great medication, and in terms of, being one tiny little medication that they can carry in their pockets, all those kinds of things for teenagers, not having to worry about spaces. This is great on a day-to-day basis, but in an emergency situation, I think it's really important that we always reiterate to families that if you do, need VVD, if you do need to go to emergency, more often than not, you're absolutely going to be having your Ventolin. And I think that's something that we always try to reiterate to our families as well. As much as they may not need Ventolin anymore, and they can use this as a reliever, Ventolin is still an important medication for them to have, and a spacer at that as well. So we still encourage our families to have those in their homes and to have in-date ones as well. So as much as this is great and it's been a fantastic change, I think, over the last few years for our adolescent group, I think it's still really important to reiterate the importance of when Ventolin needs to be used in those situations too. Next slide, please. So I hope I'm not going over too much stuff that you guys already know. I thought I would quickly just run through how to use your MDI with your spacer. So obviously, like we were saying, for our younger kids, they would have a mask on the end of their spacer, but then for their older kids, they'd be using the mouthpiece. It's really simple, and I love teaching this analogy to my families, the shake, puff, four breaths. So whatever medication, whether it's Ventolin, whether it's Flixitide, so whether it's reliever, whether it's preventer, we're always going to shake our medication. We're going to insert it into our spacer. We're going to give our puff. This, by this stage, is going to be on the child's mouth, okay, and they're going to take in good four breaths. Depending on whether it's their preventer, that may be all they need, and then they would do their mouth care. If it was Ventolin and they were needing a few puffs, we would redo the same again. Shake, puff, four breaths. We really, really love doing teach back with our families on this and reiterating the importance of how to do it. And like Kirsty was saying earlier, technique so often is just not quite right, or they might just be missing the mark. So for us, ensuring that the child, if they have a mask, has a seal across the bridge of their nose and around the cleft of their chin, and then with the mouthpiece, that they have a good seal around their lips when they're using it, are really important things. And I think just getting the families into the habit of always doing the shake, puff, four breaths, because so often we get them discharged from hospital and they tell us stories of a nurse doing it every two puffs or every four puffs or not shaking at all. So I think it's a really good, easy one for people to remember as well. Next slide, please. So looking at our turbohaler now for our big kids, okay? So our little magic bullet here that we have. So really simple and easy to teach kids to use, but same thing. If they don't do each of these steps, they could be missing the mark as well. So simple analogy, load, deep inhale and hold. But when we break it down, we're going to take the top off. We're going to twist the bottom. And when we twist it, I'm not sure if you can all hear that, but there's a little click. And that's the actual that powder being loaded in, ready for me to take a breath out, away from myself, pop this in my mouth. I would take that big inhalation in. I would hold it for a good 5 up to 10 seconds if I could, and then pop this away from myself and breathe back out again. If I needed to take another inhalation, I would do the same step. If not, I would put my lid back on and I would do my mouth care. Same thing, really important, simple, easy steps. But more often than not, we find that some families just maybe either doing a breath back in, not breathing away, not clicking or doing too many clicks. It's easy to do once they know, but it's just ensuring that I think we give them that training and show them and then get them to show us so we can then help them and support them with the correct way to do these things. Next slide. So, as I've already said, show me how you use it. It's the most simplest thing that we can do with our families, getting them to show us, importantly, how they're using their plans, how they're using their puffers, their inhalers, so that then we can give them the guidance that they need and the confidence that they need to understand what they're giving to their child and how it works. So we know using the zones on the plans is really important. We know doing a demonstration is really important, and we know then getting them to repeat it back to us in their own other words or in their own way of showing us is really important too. Gentle correction as well obviously builds confidence. We're going to do this in a way that's kind and gentle and that helps to support them to know what they're doing each day for their child. Next slide. So at home, families follow the individualized plan. In school, like we were saying before, it's our 4x4x4. So it's been standardized. Asthma first aid, it's safe, it's simple. People can learn it pretty quickly, and it can be used for any child or any adolescent or any adult, anyone at any age. Next slide. So just quickly, it's 4 puffs, it's 4 breaths, and you wait 4 minutes. So if it's a child that's come into first aid at school, tighten their chest, maybe a little bit wheezy, maybe not able to talk in full sentences. We're going to sit them down. We're going to get their plan out, make sure that they're a known asthma, give them shake, give a puff, do the 4 breaths, do it the 4 times, wait the 4 minutes and see how they feel. At that point, they would then know what the next step is that they need to do, whether it's calling 000 and giving more, whether it's calling the parent to alert them, and then the parent could obviously then come and pick them up and take over. I think, like we said earlier, explaining the process to families is really important. I don't think there's much else to say about that. I feel like we've covered that really well. What do you think, Kirsty? There's nothing else really I think we need to say. Reliever and spaces supplied to school. We all know at this time of year, I've been doing my calls the last few weeks, reminding my families, have you got your up-to-date plan? Have you got your spacer and your Ventolin that's in date, ready to go off to school? It's simple stuff, but it's stuff I think as clinicians that it's really important that we remind our families about as well. So then it becomes something that's a part of their routines too. So the takeaways. So back to school we know is like a key time where we can help prevent so many of these episodes of asthma from flaring. Plans work when they're current and when they're shared between lots of people. So families, GPs, schools, community asthma programs, whoever it is. And I think the most important thing, like Kirsty said, every interaction we have with our families is so important. So if they're not sure, if they're not getting it, we go through it again. Kirsty gets them back in and gets them reviewed. We reteach the teach back information, or we go through it in a simpler way. And that's it, guys. If there's any questions, feel free to ask away, and thanks for listening.
Thanks so much,
Can I add
Libby.
something
Oh,
about the adolescents that was so beautifully play out on how you do the plan? So helpful. One of the things I often remind my adolescent families is, in hospital, we see a lot of preschool children. That's probably the bulk of the patients that we see. However, those asthma that are really severe that, go to ICU, intubated, or perhaps in the rare cases of death, is actually in the adolescents, particularly those with food allergy, anaphylaxis. And I think it's a combination of maybe a more severe disease phenotype. Maybe teenagers have got a lot of things on their plate and not recognizing their symptoms. And therefore, I often explain that the anti-inflammatory reliever therapy means that every puff that you take has that little bit of anti-inflammatory, and that's why that's been shown to be so helpful in the big kids group, because there can be some reluctance to swap over from the blue Ventolin to the Symbicort inhaler. And just a reminder that we do see most of the morbidity and severe cases in our adolescents, and that's why it's really worth the trouble that you have explained of going through a whole new different plan, teaching them how to use the turbuhaler. I think that's been really effective once the young people and the family get on board with that.
Yeah, it's so true, Catherine. Yeah, so, so true. And that's something that we do in our education sessions is really teaching our families on the difference between the preventer and the reliever, whatever the medication is that they've been prescribed, and actually showing them pictures and physical modeled airways of where those medications actually affect. And I love that light bulb moment when we see families go, oh, so that orange one works on the inside of the airways and the blue one works on the outside. Like it's just amazing when they go, oh, so they're both helping asthma, but on different parts of the airways, and it's really nice. So it's the same thing with the older kids as well. It's nice to be able to show them it's actually doing two things at once for you. How cool is that? Like, yeah, so totally agree. Yep.
It was brilliantly presented, Libby. In the nature of the ICAM and sharing practical tips on that, I will often use a visual representation with my hands about inflammation. So I level my hands and I say, here is normal airway with no inflammation, and here is asthma symptoms. And your child's lungs with asthma will gradually get more inflamed until you get bronchoconstriction as well. And then this is where we tend to get symptoms. Now, your child can have no symptoms, but still be sitting here, not back down here. So maybe it's springtime and they've got hay fever. And then maybe they have a microdose of peanut and they're slightly allergic, we're not too sure, and they go to here, and then they get a cough and cold and they shoot above it. So I use a visual to say the reason why we're using that steroid is to get them down here to normal airways so they can tolerate spring with their Nasonex and their antihistamine and their Symbicort. And then if they do get a cough and cold, they don't top up to going to hospital. Maybe they need maybe they get to here and they need an extra puff of Symbicort, but we're not going in the danger zone. So we're bringing it. So I use that as a visual representation to say, we really want your kids down here. We want them away from the danger zone, way, way down here. And that's what the steroid does, not the Ventolin.
Yeah.
Okay, thank you so much. I can't see any more questions. I'm hoping it's because we're covering all the material. I was certainly very interested in Libby's talk. There's lots of space for questions there, so we'll move on, okay? So here's the crux of it. You can print these slides and show your patients and send them off to school. So we've all had the clinic appointments, but the school says. So we thought we've had input from the Department of Education this time last year as well. They have slightly changed things this year, so they only just got back to us today. So forgive the wordy slides, but Olivia's done a brilliant job putting them together. This is from the horse's mouth about what we can feed back to parents to take back to schools, including a helpful email address that you can direct patients and schools to ask any more questions, to offload your day, because that's what we all need, a little bit of offloading. So the Department of Education have updated the asthma, allergies and healthcare needs policies as of January. Okay, so right now, this is fresh off the back this week. So you may have seen this. It'd be interesting to know if people have had this, that a student with an asthma action plan only requires a student health support plan if their asthma is not well controlled and needs individual medical health related supervision, care adjustments at school. I don't know if other GPs have had these in, but often we'll give the asthma plan. And there's certainly certain schools that always send me back a medication authority form and a student health support plan. So this is just to say, if you've got a kid who's always got asthma, they don't necessarily need all that. The medication authority form is the asthma action plan. Now, I find it's a local private school for me that does this, and I think it's within their governance. And something really interesting we had fed back was that private schools can make those decisions. If they need a medication authority form, they need a medication authority form. And it's easy enough to do. But if you're just constantly getting these student health support plans again as a knee jerk, you actually only need to do them in these conditions. And private schools are slightly different. They can sort of make their own terms, but certainly for public schools. Yeah, it's just a bit more details. There's further guidance and strategies in the healthcare needs policy. If anybody has some spare time and needs to fall asleep easily, I'm sure that's a scintillating read, but it's there if you need it. And not that we have enough to read on our rate, but very helpful to know it's there and to signpost schools too. And the web pages, if you go back through to my pages, I've got the web page for the asthma plan there that you can just click on. That's very useful. Mostly, we have all been asked for a care certificate for a child that has been excluded from kinder school because their plan was not up to date. Under healthcare quality law, schools cannot exclude students if their health plans aren't updated or their plan is out of date. They're not allowed to. It's equitable access to education. Okay, you cannot discriminate against a child because they have a healthcare need. Now, there is obviously sometimes when it's dangerous. If a child has had a brittle asthma attack, first episode has just come out of emergency, you really shouldn't be going to school without an asthma plan. Off asthma topic, but seizures as well. If your child has epilepsy and has had their first seizure and nobody's trained and they don't have a plan, they probably shouldn't be going to school until that paperwork's filled out. But for the routine reviews that say, hey, this review date passed 3 days ago and now the child isn't allowed in kinder and school, they're not allowed to do that. I have a set template letter that I send to schools, but usually I advise patients to signpost their school to the website, which will, the email address for those questions that I'll show later. And links to the policies you'll get in the post correspondence details. The review date, to clarify, is the clinical review date. It's not that something awful has happened and then the child can't go to school. Okay, so other questions we've had over the years. So can children attend school if their asthma plan is out of date but no change has happened? So you're pending review, you've just not got round to making that appointment for your kid? Yes. Okay. So again, schools must review the action plan when updated information is received. So if they get something that tells them it should be done, it should be highlighted. A change in needs or level of support, or when the school student or parents or carers have concern about their care. Okay, but otherwise, the schools are recommended to make sure, and this is kinder as well, that they are annually reviewed by the action plan, which is sensible healthcare. Kids should be reviewed at the very least annually, hopefully more than that, as we've discussed. But it's not mandatory. They cannot be refused access to return to school if it is not done. So can they be refused participation in school camps? Another one that we get, floods before camps. Oh, it's out of date. They say they can't come. Again, no, they can't, as long as there is no acuity. If the child has just been discharged from hospital and is off to the bush for a week or two and doesn't have an asthma plan, do the asthma plan, okay? Sensible. They can't be refused it. Remember, everybody has different circumstances. Sometimes they just can't get into the GP to get it done. If it's a stable asthmatic, then it can wait till a week after. And then just, sorry to go back there. Schools can be entitled to request parent carers to provide written confirmation. So you could write a quick letter saying, I've not updated it. It's fine. I'll do it in the week back. Circumstances that I would do it is the asthma plans I obviously take very seriously, and I really do want them and their parents to attend. They need to bring their medications. I am not reviewing their asthma if I'm not reviewing their asthma. So sometimes if you do the paperwork, over a telehealth, it can be helpful, but then you do not see them again for a year. So sometimes I'll provide a letter if everything's stable, do a review, but say, look, we'll do a plan, or we'll do a plan with a week's review date, meaning you have to come back in and we have to do it again. And obviously not holding people to ransom, but trying to make sure the emphasis on good clinical review. This is a really interesting one. For those patients who are very stable, let's say they are a case from today that I had a anaphylaxis patient who's got very stable asthma, but we're keeping them on their asthma plan because they need it in case of anaphylaxis, and maybe they've still got hay fever and they're at risk of thunderstorm asthma. So I've got a few patients like this. We keep them on their asthma because they're in the high risk category phenotypically. They do get allergies in spring, and maybe they have had thunderstorm asthma symptoms before. I'm not taking those kids off their asthma plan, but for all intents and purposes, they're really not using their Symbicort very much or the Ventolin very much. Sometimes I will do a plan date that is longer than a year. Not often. It's more in the case of allergies. I'll do a plan date for more than a year, and often we get a bit of kickback saying, oh, it needs to be reviewed every year. If you have a 16-year-old who has a peanut allergy and is not growing out of it, you can do a plan that lasts 2 years. That's fine. But sometimes you need to do an accompanying letter to the school to say, and same with kinder kids for allergies. If they're not having a review by their allergist for 2 or 3 years, you can do a plan that lasts that long because it's not going to change, just with an accompanying letter explaining that. And it can't be refused. Okay. So that just explains, sorry, I'm sure you've all read through that. And schools can accept a black and white copy. Obviously, the colour copy have the benefit, it is a visual reminder. But again, that's really useful for parents and caregivers who are providing the asthma care in that modality and we're giving education to. Schools are always going to be following the 4x4x4 first aid. If you only have a black and white printer or you have terrible handwriting, you do not need to go and get a colour copy and fill it out by hand or find a colour printer. They cannot refuse them. Now, this is the key thing. I would urge everybody to take down this email. If there is constant asking, it's a waste of parents' time, it's a waste of your time. Just hand out this. This could be something you put at the bottom of the care plan, this very helpful email, and parents and schools can clarify any of their questions through this email. So the Department of Education can actually settle any questions they have without coming back to the GP for it. Obviously, clinical questions are for us, but if it's a constant to and fro of I don't need to provide a colour copy, I don't have a colour printer, then it's obviously personal choice. Some people may wish to just go find a colour copy and do it, and others may just do what they do. But it's a very useful email. If you have any questions about the school health interface as well, off topic of asthma, this is a really useful advice line to contact. So it might be about neurodiversity, it might be about health equity in schools, it might be anything. You can use that as well for yourselves. Okay, look, any questions about all that? Any other things that people find tricky in these consults? As I say, we've got a wealth of experience having done this webinar at the beginning of every school year for the last 3 years. If anybody has any questions that they find difficult or questions that they want to ask. Can't see anything come through, so hopefully we've answered your questions. So this is just a little bit of information, our plug for Health Pathways Melbourne. I'm sure you all know what it is. It's really useful. We obviously don't know the experience of asthma or related paediatric care within the group. Usually these things self-select to people who are interested in asthma, but we always presume that there's people here looking to learn more and increase their knowledge as well. So Health Pathways has really useful resources and it's very up to date on asthma. It's localised to our area. There's very clear referral information. It's updated regularly, and you can now log CPD hours by going onto Health Pathways automatically. So there's a how to log on the drop-down menu that I'll show you. So you can actually record CPD hours for looking for updates. It's easy to access, and it's free. So this is the Health Pathways page. If you're not familiar with it, in search bar, asthma for children, and then there's asthma in children acute, asthma in adolescents, primary school and preschool. So it breaks it down for you, and it breaks it down into the chronic care and the acute asthma care. My clicker's stopped. And these are all the different pathways that are related. So if you're like, oh God, I can't remember. I mean, I see childhood asthma all day long, but if you haven't seen a 6-year-old with asthma in a while, because as we know in GP, all our demographics vary, and you're like, oh God, I can't remember what the up-to-date evidence is because it has all changed a lot in the last 5 years. This is the place to go on and have a little read to be up to date. I should say CPD hours for health pathway use. Click on that and it'll show you how to log your learning. So yeah, this is just what the pages look like. I won't go through it all, but basically it's a really good way to manage your consult as well if you're not so confident about what you should be going through. This is what they've got in summary. And then referral pathways, so the non-acute referral pathway criteria, if you're wanting somebody to be seen in the hospital. And then this is how to do your CPD reporting tool. I won't go through it all, and you're all well-educated individuals who'll be able to find it yourself. But it's there, and a good way to report your CPD as you go along. If you haven't got a CPD, for the registrars or anybody more junior in the audience, if you haven't got a Health Pathways login, you can scan that QR code, leave it up for a couple of seconds, and yeah, you can log in. Okay, and then just a brief bit about the community asthma programme. Again, our plug for them. Libby, I'm sorry, I forgot you weren't in Laverton anymore. I think I'm still grieving it. I think I've repressed the fact that you're no longer there.
Okay.
That Laverton Co-Health was closed down, a huge loss to our area. I forgot it had moved. Yeah, so the community asthma programme is DHHS funded. It's a free service for any child up to 18 years of age. They provide up to hour-long reviews for anybody with asthma, new, recurring, fallen off the wagon. They will provide it via video, telehealth, in person, in home. They can even visit schools and childcares to help if there's brittle asthmatics and people feel like they want to improve their education there, or there's foreseen problems that the family have that need ironed out. Olivia, if we could have the cat